And I would like to speak about the central first technique. And if we start with the central first technique, I want to recommend you to do a distraction test before you start with the surgery, for two reasons. First reason is that you check all your joints at your fracture table, is everything well fixed. And the second reason is that you get a feeling of the ability for distraction of your hip. And some hips come out at once, these poppers phenomenon we heard in the morning. So you should gently pull on the leg, and sometimes the hip opens up after you break the under pressure of the hip. And when you start with the central, in the central compartment, it's useful to simulate your portal with the needle on the skin. You see it here, and you can move your needle onto the skin until you find your comfortable position of the needle. For the orientation, if you start with the anterolateral portal first, the orientation is approximately 20 degrees to a cranial and 10 degrees to a posterior position. And if you start with the anterolateral portal, you can see that the tip of the needle should face to the end of the sclerotic zone, to the end of the eyebrow of the acetabulum. If you compare the needles from various companies, you see that there's quite a large difference. And you can use any needle you like, but you have to keep in mind that the lower the diameter of the needle, the lower the maneuverability of the needle in the soft tissue. And if you go straight into the central compartment, then you see that the angulation of the needle is very important. If you just change the direction of the needle for about 5 degrees, and you're about 12 centimeters in the soft tissue, then you have a distance here of about 10 millimeters. You can play, or you can turn, you can play with the tip of your needle, you can turn your needle for 180 degrees, and you can play with the bevel of the needle, depending on the ability of distraction of your hip. I want to illustrate that with the next slides. So this is a hip, this is not so very good destructible. And I went in here with the needle, and you see, if I go straight forward, then I can make some damage of the labrum. So what I have to do, I have to bring the needle further down, correct the position of the needle for some degrees, and then go straight in underneath the labrum. Use air as a contrast. You see the difference between that two pictures here. You see very nicely the cartilage of the femoral head, and then continue with establishing the portal. Here's another case. Here you see that there's quite some space between the tip of the needle and the cartilage of the femoral head. So what you can do, you can turn the needle about 180 degrees to bring the bevel, the tip of the needle, into another position to go underneath the labrum into the central compartment. And here you see how it opens up, and here you see the air contrast and the capsule. I recommend very much the air contrast. Here you see it without air, and here you see it with air. So you can see the central and the peripheral compartment. You can see the zona orbicularis, you can see the labrum, and you can see even the perilabral sulcus here in this patient. But be careful with your nitinol wire. Nitinol wires can break, and then it's very difficult to take them out of the central compartment, and you can make a cartilage damage if you're not careful with your nitinol wire. So for the central first technique, for me, it's important to have a correct setup of the C-arm. I always simulate the position of the portal with the needle onto the skin. I watch the tip and the bevel of the needle. I feel the resistance of the capsule, and I don't want to feel the resistance of the labrum. And I always do an air arthrography and watch the tip of your needle, or watch the end of your needle, that it's well fixed to avoid such a double tip of your needle. Quite often I put a needle, just a needle, into the posterolateral portal of the hip. For this patients, I can wash out the joint very easily. I can suck some air in, and I do my first arthroscopy with air. And it gives me a very fast, clear sight of the hip. then I secure this portal just with a nitinol wire and I leave it there. And whenever I need it during arthroscopy, for instance, for some chondral flakes, for osteochondromas or something like that, then it's very easy to establish this portal because the nitinol wire is already in place. And this is how it looks like here in the posterior corner for the posterolateral portal. And my third needle goes straight into the anterior portal. Today I use it a little bit more lateral and a little bit more distal to avoid damages of the lateral cutaneal nerve. And you can use these aiming devices which are available from every company. And this is actually my second portal, these anterior portals. So I end up for the central compartment with 3 portals, anterolateral, posterolateral, and the anterior portal. So in conclusion, for the central first techniques, these are the advantages for me. I get a very fast and clear sight into the central compartment. I can make my conclusion from the pathology of the central compartment, for instance, from the cartilage damage, on the pathology of the head-neck area, and I have a very good maneuverability of my instruments because I have no swelling because I was not in the peripheral compartment before. These are the risks. You can damage cartilage and labrum. You have to be careful. So for me, I test the distraction of the hip always before I start surgery. I check the setup and the C-arm. I simulate the needle position on the skin. I feel the resistance of the capsule and I use the air contrast. And whenever there are problems with establishing the portal for the central compartment, or if I have a joint space below 8 millimeters with distraction, then I start in the peripheral compartment. Thank you very much for your attention.